Thank you, Dr. Musa, for the kind introduction. The case actually was a very nice introduction to my talk, but I'll be talking about calcium management during PCI, the latest evidence in imaging and orbital atherectomy. So what do we know? We know from Aluminum 4, October, and Renovate Complex PCI that angiography-guided PCI is very inferior to OCT-guided PCI and imaging in total. And this has led to changing of the guidelines. Imaging now is a class 1A for any intervention for complex, left main, or long lesions. So basically anything other than type A, you should use imaging. So, but why OCT is important, particularly in calcified lesions? Because calcified lesions prone to dissect during ballooning. They are difficult to completely dilate and prepare. They may prevent stent delivery and may prevent adequate stent expansion, which may preclude drug delivery as well. So how can OCT helping in delivering those kind of things is diagnose both deep and superficial calcium, and it will help if we need calcium modification or not. And this is through MLD max, which was shown repeatedly today, but mostly with the pre for morphology, length and diameter, and then with the max afterward. With the Alterion 2, you can actually see clearly. I always joke with Ahmad that you don't need to be Ziad Ali now or an imaging guy to identify calcium, because with AI, you could now diagnose the angle and know exactly what device you need and what kind of modification you need. Abdul Hadi will disagree with this, but that's fine. Now, after doing the OCT, you would come with the scoring system, and it would help you, and it would help anybody to decide about the next kind of modification you need. And here we're going to talk about one modification, which will be used by my colleague here and was used for the live case as well, for the orbital atherectomy device, which is a dual mechanism of action. It's a diamond back 360 coronary artery orbital atherectomy system. It does both modification as well as atherectomy. And basically, when you think of a lesion, and you start rotating and trying to sand the lesion, it will break down the calcium to small particles, smaller than RPC, which is potentially could cause less slow flow and less dissections as well to the intima, as well as less injury to the artery itself. Plus, it's one size that fits all. Finally, it's actually, this is applicable to this, that you can use one device for everything. So it's a pulse type forces that affect deeper and calcified plaque in medial layer, and it will help to prepare the lesion, and it will facilitate post-stent fracture, which will at the end make you be able to deliver the stent and post-orbital atherectomy, and you can achieve the suitable MLA. With that, I will leave to Ashraf, who will take you over a case demonstrating all of this.